It's so important that throughout your career, whether it's in medicine or public health or whatever field you decide, to just try to really do the right thing. Try to lead your career with your moral compass and ultimately try to impact populations that need it the most. And I assure you that your lives, both professionally and personally, will be very rich and meaningful.
From the USC Leonard Davis School of Gerontology, this is Lessons in Lifespan Health, a podcast about the science and scientists improving how we live and age. I'm Orly Bellman, Chief Communications Officer. Lessons in Lifespan Health is supported by the Ney Center for Healthspan Science. On today's episode, meet Dr. Tyler Evans. This USC Leonard Davis School alumnus has been on the front lines of major disease outbreaks around the globe. He was in South Africa at the height of the AIDS crisis, and he treated Ebola patients in Sierra Leone. He recently joined the New York City Emergency Management Department as the Chief Medical Officer for COVID-19. Evans, who's also an adjunct professor here, joined Professor John Walsh to discuss the current pandemic, global health, and how students can best serve populations in need. Here is their conversation.
Hi, I'm Professor John Walsh from USC's Leonard Davis School of Gerontology, and today I have the unique pleasure of talking to my friend and interviewing him as well, Dr. Tyler Evans. He's a medical doctor. He's a public health expert. He's an alumni of the Leonard Davis School of Gerontology, and he's also an adjunct professor in our group. And he's my resident hero. He's serving on the front lines of New York City right now. So Tyler, how you doing, buddy?
Good. Things are starting to stabilize here. The hospitals are starting to sort of build up their sort of internal capacity. I've been working at a center. I'm at the Billie Jean King Center, which is, if anybody has seen the US Open, this is where it's played. So it's a field hospital. We've got 470 beds, and we were essentially created to offload patients from the New York City public hospital system. So the fact that the hospital system in general is starting to stabilize, our numbers are also sort of, downtrending, which is a good thing. So people are starting to get acclimated to the process. And a lot of times in disaster responses, you basically kind of get all the ingredients before the recipe is designed. And I think now we've actually kind of developed the recipe and we're able to kind of appropriately distribute the ingredients into the appropriate pots.
That's great. So I want to give our viewers a little bit of background about you, Tyler, and the journey that you've had that's gotten you here today to be serving the New York community. So Tyler is the Chief Medical Officer I'm going to read this right here, at the County of Santa Cruz Health Services Agency.
That's changed.
Okay, all righty. He had been there, so where are you at now, Tyler?
I just started as Chief Medical Officer for the New York City Office of Emergency Management, focusing on COVID-19.
Very cool, very cool. He did get his Bachelor of Science degree with us. It was a while back, 2002, and he was the Alumni of the Year a couple years ago in 2018. It was awesome. He was in LA at that time, so it made for a great party. So after Tyler got done with USC, he went on to Columbia University and got his Master's in Public Health 2005, and then after life experiences, he saw that he really needed to get his medical degree, so he went on and got his medical doctorate degree at Sackler School of Medicine in Tel Aviv. But this is where I like to just get real. This wasn't a straight path, was it, Tyler? I remember you sitting in my office. You were ready to rock and roll and go to medical school, and then you said, John, I'm not feeling it. I think there's something more out there for me. And if I remember correctly, you joined the Peace Corps and you traveled. And tell us about that path.
I think you're right. Nothing about my life has been linear. And I think the most value in life is found in the nonlinear path, right? When you're the most sort of substance is discovered, you least expect something. I had a bit of adversity in my youth. And so for a number of reasons, I decided to kind of travel an anachronistic path when it comes to medicine. So I went to study public health before medicine, which was one of the best things that I ever could have done, because I kind of got the 30,000 foot sort of view of what healthcare actually looks like before I got the technical skills of how to sort of operate within that sort of paradigm. So I did apply for the Peace Corps. That fell through. I was supposed to be in Uzbekistan. So in the world of development, a lot of things just don't go as expected. So that did not. And I ended up teaching in Japan, Korea, Thailand. I was teaching English, Spanish, sociopolitical philosophy. I worked for a while in Africa, a lot of nonprofits. I got a position with UNICEF, United Nations Children's Fund, focusing on prevention of HIV amongst adolescents in southern India. And then, I decided I needed to get a real job. So I applied for medical school, and I started at Boston University. I got back to the US, and things were a little too normal for me. It just didn't sort of resonate. I mean, I had been working with quintessential poverty and disease, and now I was immersed in privilege. So I packed up my stuff again, and I moved to Southeast Asia, and I wrote a book. But before I did that, I actually applied to some unique programs where I could spend at least half the time in the global South, outside the US. And I was in a jungle cafe one day checking the internet, and there was a congratulations letter or email. I decided to study in the Middle East as a program affiliated with Columbia University, and 17, 18 years later, here I am.
Now, I know you're just a consumer of knowledge, and you can continue to get the specialties that really are going to help people that are most in need, the underserved populations. You went on and got a specialty degree in tropical medicine and hygiene. You've worked just tirelessly for HIV infected patients and people that get AIDS. So how has that really driven you as well? Just getting all these more and more information that can help deliver. Also, you do just incredible amounts of work and support for immigrants and the special need for them.
Yeah, thanks. So I was stripped of, despite the fact that I had privilege growing up, being a white male in the United States, I had that privilege. We all know that exists. But a lot of the sort of perceived privilege was sort of stripped of me at a young age, losing my family. And so I guess sort of experiencing that adversity allowed me to connect with other people that also had sort of adverse backgrounds that understood what it was like to struggle. And I just felt that I connected to other people that had that struggle, and I wanted to make their lives better somehow. And so I was actually at USC. I started going into Mexico on weekends with a group of doctors, and seeing that contrast, seeing the suffering that's taking place on the other side of a border, it just never sort of sat right with me. And we see it within our own sort of borders as well, but it's, that contrast is particularly sort of stark when you're traveling across international borders, particularly the contrast between the US and Mexico. That just progressed. I ended up going to Sub-Saharan Africa in 2001 for the first time. I had gone as a child, but to work, first time I went was 2001 in Uganda, and then in South Africa. And I was, there at the time when HIV was really under the sort of international spotlight. I mean, it has been for a long time, but at that time, there really was a lot of focus on the issue. So South Africa had the highest prevalence at the time, and it was everything that I wanted. It was excitement, it was social justice, it was traveling, it was politics, and that connected with my moral compass and my global view. I had traveled a lot as a child, and it just made sense to me. And so, I decided at that point, if I'm going to be working through medicine, and at the time I was a public health student, but if I was going to be working through medicine, actually, or public health, I really wanted to focus on the fields that impact vulnerable populations the most throughout the world. And that's infectious disease and tropical medicine, particularly tropical medicine in tropical countries.
And that can lead me to an opportunity to you just kind of dialogue. I thought I might show on the screen some of your life history here, and then you can just kind of walk us through this. What do you think about that, Tyler?
Yeah, yep.
Tell us what we're looking at here, Tyler.
So that is a soccer stadium that was abandoned at the time because that's in Freetown, Sierra Leone. So that was the largest Ebola outbreak to have ever taken place. The Ebola outbreak in that particular, in Sierra Leone, was the case fatality rate was around 30%. So that meant roughly 30% of people that were infected were dying. That was a little bit more sort of favorable than some of the other countries. Guinea, on the other hand, had a case fatality rate around 50%. So despite the fact that it's a beautiful, presumably sort of convivial city, it was a very morbid time. And at the time, there was only roughly 60 doctors in the entire country with a population of over 2 million. So
there you are as a doctor. So
yep.
What was that experience like, Tyler?
So I was working on the Ebola treatment units. Being in the suit, it looks glamorous, it looks cool. It's not so glamorous or cool when you're inside the suit. particularly in hot Western African country during the summer. So it was around 110 degrees. So we actually could not be in that suit for more than 45 minutes when we're in the Ebola treatment unit. And meanwhile, you're so concerned that if there's the smallest little rip in that suit, you could have exposure to Ebola. And number one. Number two, even if that didn't take place from a safety standpoint, you may actually have to be sent back home. So a lot of anxiety, a lot of discomfort. So despite the fact that, they look cool and interesting, Ebola fighters and whatnot, there was a lot of anxiety associated with that suit.
And I'm going to run through this rapidly because I have another question here, and that is how was it working with the people it was their community?
Yeah, so these folks here, half of them were local Sierra Leoneans. The other half were brought in from neighboring countries. They're just beautiful. Beautiful people. Africans are so full of life, so full of promise. Despite the adversity and the struggle that they have, they are people full of hope and promise. And they just get by, every day with. And I'm generalizing, this is not for everybody, but they get by every day with often very little, but it's not about material value, it's about quality of life. Right. These folks too, all their different backgrounds were written on their PPE. And I just wanted to underscore how it's not just all about the doctors, right? It was that first gentleman on the right actually was a cleaner. That's actually one of the riskiest positions out there. And of course, their pay was not commensurate with that. So we talk about sort of heroes all the time, but we often forget about, sort of risk of other people and, other sort of heroes, basically.
Right. Absolutely. I've been talking amongst, a lot of people are coming to me. I have enough of a flavor of what's going on in medicine that I can at least address some issues and where we're at with this pandemic. Sadly, our strategies are not too different from the Spanish flu of 1918. We don't have right now much at our disposal, do we?
No. Despite the warnings, we, including Ebola, we were not ready at all. We knew, folks in the public health, especially in, the communicable disease world, we knew that the greatest threat to society was not necessarily going to be war. It was going to be microbial sort of onslaught. And if the infrastructure is there, I'm not saying it's not bad, but it's the risk is definitely mitigated. And we were not there. We're getting better now, but we were not ready. The U.S. anyhow. There are certain countries, South Korea, for example, Germany, Singapore, these were countries that had a much better in public health infrastructure when it came to infectious disease outbreaks. The most important thing is having capacity, having an incident control system that can respond to it appropriately. Having a healthcare system that's functional to begin with, having a population that's relatively healthy, right? And that comes with access to healthcare, including sort of universal insurance, and the U.S. clearly doesn't have that. So there was a delay, and when we look at variability, even between states, and certainly even sort of within states, within cities, we're going to see a lot of. When you look at the granularity, you're going to see a lot of differences, and those differences, I think, really highlight the disparities that naturally exist throughout this country.
On the surface, it appears that the immune system, in the worst case scenario, patients is overreacting. We're getting this kind of cytokine storm. It looks like almost like sepsis that happens, like in meningitis and stuff, things in diseases like that. We're seeing lots of reports of really, and I think we need to get this out there. Really, really young people are starting to have coagulation problems and having strokes. So there's a lot out there suddenly about that. So I don't know what your take on that is.
I wanted to clarify that, when it comes to COVID infections, up to 95% of them are really kind of mild or moderate conditions. And so I'm not minimizing it, but it's similar. It is an upper respiratory infection. It is. And just for context, the beta coronavirus, which causes SARS-CoV-2, which is COVID-19, is also a part of the same sort of family that causes the common cold. And when it comes to, for example, OC43, which causes the common cold, roughly 5 to 15% of adults have antibodies to it. So, this is not completely unfamiliar to us. What is causing the difference is two things. One is the efficiency of transmission, and that's mostly because of the zoonotic, so that's animal to human transmission. So the fact that it hopped over to a completely different host, which is the same that took place with SARS-CoV-1 or SARS in 2004, as well as MERS, which is Middle Eastern Respiratory Syndrome, which essentially was first identified in 2014 and continues episodically every year. So all of these are in the same sort of family. Genetically, there are differences, and most of those differences, the novel beta coronaviruses, which are SARS-CoV-1, SARS-CoV-2, and MERS, are all novel as the result of this zoonotic transmission. So it's a more efficient transmission, mostly because we don't have that immunity. And then also how it impacts the pathophysiological process is distinct as well. And that part's not exactly clear as to why this has, a higher case fatality rate than, for example, in the common cold. Having said that, the case fatality rate for COVID-19 is roughly, the modeling describes it as roughly 1.38%. That is substantially different from SARS-CoV-1, which was roughly 9.4%, and MERS is at about 34.5%. So big differences there.
Right.
And then, sorry, I completely lost your question. So 90 to 95% essentially mild, moderate, sort of upper respiratory illness. And when I say moderate, that could even include lower respiratory tract infection, which is often described as pneumonia. You're going to be sick. You're not going to feel well, but you can isolate at home. You don't actually really need to see a doctor because the medication is not clear at this point. And, we can talk more about that, the evidence for the management of the disease. But really what we're mostly doing is supportive treatment. Now that 5% roughly, that's what I'm seeing. So I've got a bit of a bias, in terms of the folks that I'm seeing the sickest. And, I got to be honest, I'm sitting here in a tennis field hospital with incredibly sick people, but they all have, we refer to it as the sort of social determinants of health. They all have a number of either chronic comorbidities. They are people that historically don't have great access to healthcare. So there's a lot of factors involved that have led them to be more vulnerable for sort of adverse consequences. Yeah, we do see the cytokine storm. We are seeing some ARDS, which is essentially the most sort of severe component of respiratory sort of distress. ARDS is a acute respiratory distress syndrome, and that's when you're seeing kind of like the white out of the lungs and whatnot. And for those folks, we do need to intubate them sometimes. But listen, like I had an 81-year-old Palestinian woman that we were treating, and some of the others said, no, she's gone. She started decompensating, and we were going to need to intubate her, but then she was what's called DNR, so do not resuscitate. So we didn't. There was discussion about her having comfort measures only, which means just kind of letting her sort of sunset off. And I saw something different for her. I said, no, let's treat her, just with the appropriate antibiotics, because I think there was a super infection involved, a bacterial infection. And we did, and she responded, and she was sitting up yesterday, and she was smiling and laughing and eating, and she was going home. This thing can turn around very quickly. So as long as we have the infrastructure in place, and we're staying calm and just doing what we do best, which is manage complications, I think it will be fine.
That's great. So I have a couple student questions, Tyler. So Wuri Lee is in my Gero 414, the Neurobiology of Aging course, and she is from South Korea. So she went back to South Korea. So she's mentioned that their public health, of course, South Korea is a very different culture, but they were totally on it, and everybody's worn masks for a long time. And so they're down to about 10 cases per day. But she's worried about the summer, and there's a lot of folklore about temperature and transmission of this disease. So what would you tell Wuri about that?
So the feeling is actually the hotter, and this is not, we don't really have evidence. There's a lot of theoretical principles. The feeling is that if it's warmer, you're going to be at reduced risk of transmission, which is potentially why some of the countries in the global south did not have the transmission as it did in the global north. But there's a lot of factors to that. You know, listen, like to my point earlier, South Korea is one of the model countries when it comes to managing sort of infectious disease outbreaks. Part of it is it's a great healthcare system, great educational system. You know, the other part is they've had exposure to MERS, they've had exposure to SARS. So, you know, they're well equipped to deal with it. So I wouldn't worry about it. We can't move forward in life being afraid to come outside. We can't move forward in life being afraid to touch other people. I do think that the shelter in place measures were a good thing. I don't think that we completely thought out all of the unintended consequences on the most vulnerable populations in the US and abroad when it comes to food insecurity, when it comes to other chronic diseases or whatnot, access to care. Fortunately, those that have access, you know, in the US or other countries, you know, could have escaped to their summer home or, you know, their country home where there's not many cases and there's a system connected if they did get sick. Unfortunately, the vast majority of folks living in developing countries do not have that luxury. So if they get sick, they crash pretty quickly. But, you know, the majority of people, they've got to get back out at some point when it's safe, once our infrastructure is stable. And the reality is a lot more people are going to get sick, but that's okay because we're trying to move towards something called herd immunity ultimately, but it's got to be regulated. It's got to be done in a way that we re-enter the society in waves so we can control the consequences. And, you know, over time we'll get a little sick, but we'll respond and we'll be a healthier society in the end.
So she also had another question in that she wants to do something, and is there opportunity for undergraduates that envision themselves becoming medical doctors someday to volunteer, like say at facilities where you're at right now?
Yeah, I think when it comes to COVID and listen, like it's not just COVID, right? I mean, COVID was an awakener for a lot of people. I mean, this is the reality, what we're dealing with right now. And then this is a light version of some of the outbreaks that take place, whether it's Ebola or dengue fever or malaria or TB. I mean, malaria has a predilection for pregnancy and infants. So, you know, seeing children that are, you know, 6 months to a year old that are dying of cerebral malaria, these are preventable diseases. And with the appropriate management, you know, it doesn't have to happen that way. So this has been happening for as long as medicine has known. This sort of awakened folks that are living in countries like the global north that don't have that risk of infectious disease. And, you know, there's a lot of silver lining to COVID. I think hopefully it'll kind of bring us all together in more solidarity across the world to better understand that we are really all in this together, despite the fact that the term's a little cliche. You know, I think that if people really listen to what that means, they will grasp onto it and really understand how, you know, we focus so much on differences, but the reality is we really are all, you know, potentially impacted by this. So, you know, there's a lot of opportunities to get involved, not just for COVID, you know, for the prevention or management of other diseases. You don't have to be a physician. You know, you can be a student, but you got to find ways where your contribution is not just meaningful to you. I mean, I've had a number of really meaningful and translatable sort of transformational experiences throughout my own life. But we also have to ensure that we're giving back to society when we're kind of doing these internships or whatnot. So finding something that might not be as glamorous, but, you know, could truly be sort of, you know, meaningful and helpful is good. You might be, you know, having to create a database or code or to develop infrastructure. I mean, that's a lot of the developments are not as sexy and cool and exciting as people think they are, but it's all of those parts ultimately end up, you know, leading to our ability to save lives. So finding your niche, finding something that you're really good at and doing it and contributing is important.
So I have one other student had a question. Her name is Bianca Alonso Bermudez, and she's very interested in what you've been doing. I talk about you in my classes a lot, Tyler, and she was looking for advice about should she get her master's in public health first? Should she go for a combined program with MD and MPH, or what's your take on that? What would be your advice to a young student?
Yeah, I mean, so I would have to understand more, about her path. But I would say that if you're going to go into a field strictly clinical medicine, if you really want to kind of understand the intersections between clinical medicine and public or population health, I think the MPH is absolutely vital. And so if you're really going to be a thought leader, a game changer, a leader in the field of healthcare, I think the MPH is absolutely essential. There are other graduate degrees that you could get, Masters of Hospital Administration. Some people go for the MBA, which is helpful. It's not my thing, but can help. Masters of Public Policy. There's a lot of other sort of opportunities out there. But my experience and my understanding of other people's experience is that the MPH has been a really meaningful and had a very positive influence on people's lives and their professional trajectory. So yeah, I mean, I would do, and I would actually even, I did it, like I said anachronistically. I just say that because most people do it afterwards, but it's not necessarily out of sequence. I actually think it makes more sense to do the MPH before you do you go into medicine, because then you go into medical school understanding kind of why you're doing it, instead of just learning biochemistry and pathology and going on the wards. You really understand healthcare in a bigger picture.
So Julie and I and the Leonard Davis School of Gerontology would like to tell you and your wife Nancy congratulations, if I read that right, which is pretty awesome. Yeah. So when is she due?
So early August, late July, and it's hard being out here now, because, of course I want to be with her, and I just took on this new position, and who knows when it's going to end, right? I mean, I'm managing the medical responses for COVID in New York City. So it's a pretty high level position, and it's there's a lot of work to do. We're focusing on mostly the isolation of vulnerable populations. So the homeless, housing insecure, et cetera, and trying to, again, mitigate the risk on the population. So I love the fact that I'm able to do this, but, I am longing to be with her, and, just hope that we can be together before the baby is due. And of course, I don't want her to come out here, because then there's, there's risk. I mean, it's, depending on where you're at, the prevalence seems to be somewhere between 7 to 20%. Most of the evidence so far suggests that pregnancy is not a risk factor, but it's not. Those are not odds I really want to play. So she's going to stay back in California, which, when you look at, New York versus California has done considerably better than New York.
Yeah, for sure. And I was thinking about this, and my guess is your college-age daughter's got to be pretty excited about having a new sibling coming around too.
Yeah. And she's I think that she's at USC studying global health. So the apple doesn't fall very far from the tree.
Yeah, that is awesome. That is awesome. Well, I just want to say that the Leonard Davis School and the University of Southern California, I want to thank you, Tyler, from the bottom of our hearts, for all the hard work you're doing right now, all the important stuff you're doing right now, all the stuff we talked about in the past, and I'm sure all the incredible things that you're going to be doing in the future. And we want to maintain this relationship with you. And obviously I will. Tyler and I have been buddies for a long time. I remember Tyler put me on the list to look at his thousands of photographs. And so my whole life, I've always been watching Tyler's photographs, and it's just been fun to be part of that. And I think we're going to continue to be part of that.
Thanks, John. And thank you for being a mentor and supportive of me in my early age, and continuing to sort of support me. It's really meant a lot to me. And I just wanted to say one last thing, for the students that are watching this, it's so important that throughout your career, whether it's in medicine or public health or whatever field you decide, to just try to really do the right thing. Try to lead your career with your moral compass, and ultimately try to impact populations that need it the most. I assure you that your lives, both professionally and personally, will be very rich and meaningful. So the world needs you guys to really, to help populations that are in need, whether it's now or whether it's building it or whether it's in acute management. And again, like I said, it's not just healthcare systems, it's economics, there's so many intersections in our globalized world. And as long as folks, really, lead with their moral compass, I think they'll have a very meaningful life. As I describe it, I'm often a humanitarian who happens to be a doctor. So, I lead first with the mission, and I take my skills with me.
And hopefully, through your efforts, maybe medical schools will start having a curriculum that is called humanitarian medicine.
Yeah, I'd like to be involved with that.
Yeah, that's awesome.
Yeah.
All right, thank you, Tyler.
That wraps up this lesson in lifespan health. We'd like to thank Professor John Walsh and Dr. Tyler Evans for their time and expertise, and all of you for choosing to listen. Please subscribe to our podcast and learn more about us at lifespanhealth.usc.edu.